I just can't swallow it anymore.
Understood.
Just like there are a number of fast food restaurants I no longer go to. Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We trust that you have had a good week. We are pleased and happy that you chose to spend this time with us, and I think you're going to be pleasantly surprised by how you are going to be informed today. Without further ado, I will turn it over to our founder, Dr. Randall Maxey.
Thank you, Dr. Barbara Neighbor-Stevens, Dr. Avenwalks, and Dr. Hind. Appreciate all of you so much. We're going through some changes in our format, doing some experimenting, and hopefully in the next week or so, we're going to meet with our advisory board and see what we're going to do going forward. So we have a planned way to discuss things, but first I want to take a moment of personal privilege that I just got notice today from one of my lifelong friends and colleagues growing up has passed. He was actually a psychiatrist, Dr. Walks, and Dr. Joe Simpson. I just got a message from another one of our group who was one of the first federal judges appointed by Reagan that he had just passed a few days ago, and I'd like to give honor to his passing and hope his family does well through this. But we're going today to have a roundtable discussion on hypertension management. And I've had recent experience with other close friends who are getting more senior with having abnormalities in the management of their hypertension. So we have 4 specialists, and I'm going to be the moderator, and I'm going to be the specialist in internal medicine. Dr. Neighbor-Stevenson is a specialist in pediatrics. Dr. Hines is a specialist in family practice, and Dr. Walks is our resident psychiatrist. And we're going to just go through discussion of high blood pressure and talk about the various aspects and have a discussion about that. So we're going to examine the latest information. Dr. Neighbor-Stevens has suggested that there are new guidelines of how we talk about hypertension, and we're going to discuss some of those. So let's talk about the 2024 American Heart Association guidelines. And they have different high blood pressure classes, but some of them have remained the same. There's a classification called normal. There's elevated blood pressure. Then there's stage 1 and stage 2 hypertension. However, one major change is what happens on the long term from hypertension effects, and that's what we want to talk about. And we can calculate this using certain updated tools. And I put a patient of mine who's very close to me into the calculator to talk about long-term risk. And I put him in as a 79-year-old man with moderate hypertension, with a slight decrease in kidney failure, no issues with cholesterol elevation. And over the next 10 years, he has a greater than 40% risk of having cardiovascular complications. And we also know that approximately half of the people in this country have high blood pressure. Another figure, maybe half of those people don't even know that they have high blood pressure. So it's a large number, and that fits around the world, especially for people who have color, people who are older, and males. So these guidelines take all of this into effect. But let's first ask Dr. Neighbor-Stevens, how does this updated approach improve or impact on pediatric care?
Well, the the interesting thing, and I want to be upfront and clear about what is known and what is not known. The interesting thing about our concern about high blood pressure in kids is, first of all, the increasing number of kids that have high blood pressure. Now, having made that observation, then the next question is, of course, what do you do about it? And the issue with kids and hypertension is we presume, and there are studies that link hypertension in youth to hypertension and further cardiovascular conditions in adulthood. But what is not clear and what has not been adequately studied is the direct link and what should be appropriately, how these kids should be managed. So, and one of the reasons for that, one of the big reasons for that is most of the drugs that are available for the treatment of hypertension really haven't been tested on kids. And so that leaves a big question as to what is safe, when is it safe to start it, and all of the issues associated with drug safety in children and adolescents. So the American Academy of Pediatrics, while recognizing the significant increase in the incidence of high blood pressure in kids in this country several years ago, has still taken the position, most recently still, that the approach to managing kids with high blood pressure is to influence lifestyle behavior and weight loss. Because what has been shown is that there is a lot of high blood pressure in kids who are obese. So there is the information from the studies coming out now that shows that with weight reduction and lifestyle changes, you can impact the blood pressure in children and youth. But whether or not that is sufficient, whether or not additional treatment should be initiated, is still an ongoing research question.
Uh, Hold on. Well, I wanted to go back to our family practitioner, Dr. Hines. How does this impact the practice that you have taking care of both young people and old people?
So thank you for swinging that. That's a right to follow up right from Dr. Nabert Stevens' comments on, weight loss and activity as a moderator for blood pressure. I'm just going to go back another step first, though, because we talked about the different categories, and I'll just give you the numbers that are associated with the different categories. So now, elevated blood pressure starts at anything from 120 to 129, right? As the top number, and then anything above 80 is problematic. And then hypertension stage 1 is if your top numbers are between 130 and 139, and your bottom numbers are between 81, right? And 89. And then stage 2 is 140, anything above 140 on the top, and anything above 90 on the bottom. So those are the places where we're talking about, areas of concern, because that's not what it used to be. It used to be higher, right? Where people started to get concerned and talking about medications and lifestyle changes. So in talking in particular for kids, because there's we're not putting kids on diets, right? But just what adults and kids have in common, physical activity alone, even without weight loss, can have a positive impact on blood pressure. And for those who are overweight, adding in the weight loss is going to have even more of an effect on blood pressure management. So these new guidelines are also incorporating the importance of having that doctor-patient relationship where you can talk about what do we want to do here, right? So if you're in the normal elevated stage 1 category, that's a space where, and you don't have some of the higher risk factors that Dr. Maxey was discussing earlier, that's when you get a longer period of time to do some of these therapeutic lifestyle changes, which is, weight loss change. I'm going to change my diet. I'm going to start exercising. Those types of things are in the therapeutic lifestyle change space. And sometimes, on average, the recommendations that are associated with these guidelines say that if you're in those, stage 1 or elevated, you can get about 3 to 6 months to try to figure it out, right? If you're stage 1 and you have some of those additional risk factors, or if you're stage 2, typically the guidelines say you got 1 month to try to figure it out before we start medication management, right? And again, it's meant to be a discussion between, you and your provider to discuss those risk factors and discuss those, so that you all can come to an understanding together. Because lots of times people are mortified and shocked when it's time to start, high blood pressure medicine, and they don't want to do it. So sometimes you need that time just to get adjusted so that then you can get to compliance, to get a blood pressure cuff at home, right? So that then you can know what your actual readings are. Because the important thing there too is that moment in time at the doctor's office, well, that's not your regular life, right? Your regular life is however it is when you're doing your normal routine. So your trip to the doctor's office could have been more stressful than usual, or maybe you took the day off that day because you had to go to the doctor's appointment and your blood pressure might be lower than usual because usually you're at work hustling and, fussing at people, who knows? So that's, I think, the biggest place in family medicine. And when you have a personal provider, you all can have those conversations and discuss what's best for you based on your personal risk factors. So Dr. Walks, how do you see this impacting mental health?
So thank you, Dr. Hines, and thank you, Dr. Maxey, for us coming together to talk about this in this way. The first thing this does is it reminds me of just the inaccuracy of talking about physical health versus mental health, because so many times folks try to make that arbitrary distinction between the two, and it doesn't make any sense. Mental health and the impacts on your body are absolutely very closely related. Chronic stress, anxiety can increase blood pressure. Dr. Hines just mentioned being in the doctor's office or on the way to the doctor's office can cause some stress and result in some blood pressure changes. The other thing is antihypertensive medications can sometimes impact your mood. So you're treating your blood pressure with the right medications, but it's having an impact on your mood and even on your cognitive function or the way that you think. And then sometimes something that may not actually be as clear, some of the blood pressure medicines that folks take may send you to the bathroom a lot. Depending on your job, depending on your responsibilities, that can have a significant impact. If you've got to get up and run to the bathroom and you work on some sort of an assembly line, you talk about increasing stress. It can be very stressful. So as Dr. Hines mentioned, that conversation is important to talk about what are potential side effects, more common side effects, and how they may impact your life can really have a significant impact on your medicine compliance and therefore the effectiveness of the medications. So as psychiatrists, we have to be involved in shared decision making, especially when it comes to monitoring for those side effects, and in patients who are managing mental health conditions alongside hypertension. We used to talk about folks who are dually diagnosed. Sometimes folks are triple diagnosed or quadruply diagnosed, and they've got all kinds of different things going on. So these newer guidelines, as Dr. Nabret Stevens mentioned at the beginning, really reinforce the importance of individualized care. Having that practitioner with whom you have a good relationship, who will take time to explain to you what the consideration should be, and then listen to what your concerns are so that adjustments can be made as needed. So that's what I have for the moment, because you guys want me to just talk for the whole rest of the time that we have. So Dr. Maxey, um, I was talking about the individualized care. So either you or Dr. Neighbor Stevens can jump in and talk about populations that might be at higher risk.
Well, Dr. Max is on mute. I don't know. Are you talking?
He was on mute.
Can you hear me now?
Yes.
Now we can hear you.
I'm sorry. Of course, the population that we know are most high at risk are the Black population and the Hispanic population. And they have a higher incidence and as well as prevalence of hypertension, but it does go across all other ethnic groups as well. Now, this is partly due to social and environmental factors such as healthcare access and economic barriers, but it's also a major genetic component. And we talked before about the APOL1 chromosome that has abnormalities in genes that come from people who the ancestors come from West Africa. We're not going to discuss that today, but it does leave more of us at risk for kidney failure and hypertension. So that's something that we should know, that we are more at risk. From a family practice standpoint, Dr. Hines, I know you've been very involved in hypertension care, but some of the disparities, can you describe what happens in your population?
So I think oftentimes a lot of our minority patients sometimes live in urban environments, right? So for example, if I say go out, if I'm giving advice to my patients, so for a while I practiced in Baltimore City. So if I said, I want you to walk outside for, 30 minutes each day, well, in some places, that's a reasonable recommendation. In some places, it's not a reasonable recommendation. Not necessarily, I mean, crime aside, it's aesthetically not pleasing, right? Like, for example, when I lived in the city, there were times if I took a walk, I'm going to pass, rodents. I'm going to pass the smell of urine. There's going to be trash. Like it's just not, I used to walk to my clinic intentionally, right? So that then I could be more aware of some of the things that I was saying to my patients. So that one is not always the best option to give if you're not aware of the communities and the environments that, for example, your patients live in. Also, when we're talking about fruits and vegetables and things like that, well, food insecurity and food deserts are increasingly a problem across this country, even in places where you wouldn't imagine. Orlando, Florida, has quite a few food deserts, right? And who would think it's a major city? Like, you mean the happiest place on earth has food? Yes, yes, it does. So again, when you're talking about food options, you want to make sure that you're saying things that are relevant to the community and the individuals that you're talking to. Because sometimes, again, when I lived in the city, the closest only the corner store was selling fruit. Well, they're selling fruit at an extremely high price. I wouldn't buy, more than one or two oranges myself. So making sure that you're giving people options is important. In dealing with those things. And additionally, if we're talking about, some of our minority populations, we have to be, poverty is an issue, right? If I have higher priorities on my list than medication, the cost, paying for my medications, compliance with my medications, access to the pharmacy and those types of things, I've got other life pressing things that I have to consider, not to mention, as Dr. Walks was talking about earlier, the chronic stress and things that we now know are not only an immediate factor, but they're also finding, genetic links, genetic changes that are happening that are predisposing us to some of these issues later on. Transportation is sometimes an issue for people getting to, again, their refills. For example, sometimes, okay, yay, I have my pharmacy. They're supposed to fill my medicines, automatically. Well, every time I go, they're out or that it's not ready, or they sent me the little email, but it's not there, or you're getting your, 3 months thing in the mail. But what happens if it doesn't come on time? All of those types of things can be an issue. And not to mention, there's a lot of racial guidance in prior blood pressure recommendations, which might steer providers towards certain medications that may or may not be best for you individually based on, some of the other factors that we've already mentioned, either other conditions that you have, other things in your life. It just may not work for you. Yes, I'm Black, and it says I should take Norvasc, but for whatever reason, Norvasc is not working for me. And sometimes as providers, we need to understand and remember that those are recommendations. And what we can do as a patient is remember to say, hey, I'm taking this every day, but I think my legs are swelling, right? Can you check that out? Because I'm having a side effect and this isn't working for me. So those are just some of the factors that can sometimes contribute to minority populations having disparate outcomes. And again, all of this stuff is important to make sure that you're doing that shared decision making. Dr. Neighbor-Stephen, do you see some of these things in the child and adolescent population as well?
Well, yes, and some other areas that we've kind of touched on, but I want to go a little bit more in depth on. But first of all, there are some kids who are at a higher risk due to certain genetic factors. Also, there have been several studies now that have shown an increased incidence in childhood hypertension and adolescent hypertension in the offspring of women who suffered from preeclampsia or eclampsia during pregnancy. The thought, and it's kind of logical, that something impacted them in that intrauterine environment where the mother was suffering from elevated blood pressures. There are kids who have congenital and acquired kidney disease that are at a higher risk for high blood pressure, as are the kids who develop the now archaic terminology, diabetes type 1 and type 2, but they are also at an increased risk. I want to bring up two other areas related also. We touched on stress before. People don't understand that kids are under a tremendous amount of stress. 10% of kids have reported thinking and or acting out on suicide gestures. So I don't think we understand how at risk our kids are these days. For the underrepresented minorities in particular, we have talked a number of times about the impact of race. Children also can be subject to physical bullying as well as online bullying to a degree that sometimes we are not aware of. And stress can, along with other risk factors, obesity, high sodium containing diet, my pet peeve, maybe and other dietary indiscretions, as Dr. Hines was describing, the inaccessibility of good quality food. All of these can lead to the expression of all of this in the child and adolescent of high blood pressure.
Well, thank you. Dr. Walks, given what Dr. Neighbor-Stevens and Dr. Hines have been talking about, myself, what are some of the other social factors that might play a role in mental health and stress levels that happen in these children? And also, would you comment on I heard a TV show last night that talked about that many of our kids are concerned about as they're teenagers with gender identity. Is that a role, something that happens?
Well, Dr. Maxey, we can go all the way, as they used to say, all the way around the barn. And every place we look, there's going to be some impact on on mental health. And we mentioned a little bit ago about individualized medicine. The reactions that people have to experiences around them vary from person to person. So getting punched in the face is bad for everybody, but other kinds of insults may be differently bad, or the impact may be different. So when we're looking at some of the social determinants, looking at economic hardships. Dr. Hines talked about um, some of the things that she was impacted by walking down the street in some inner city areas. I was walking down the street last night and looked at several people who I was walking by where they lived. They lived on the street, and they have. So when you combine home insecurity with food insecurity, and then um, one of the social determinants, I don't know that we've ever really considered a social determinant, is just the only polite word for it is unsettled, the unsettledness of our society right now. If you have a young person that is watching television and they're seeing some of these political ads about just how bad this person is or how dangerous that person is, and they're coming from, I would like to say both sides, but I think it's really all sides. There's a lot out there to make folks feel uncomfortable and feel unsettled. So when we look at there was an announcement about an ad about how if one person wins, all the federal jobs might be at risk. And so job insecurity is a big deal for the person holding the job. Job insecurity is a big deal for the family of the person holding the job. And so there are all of those kinds of things. Limited social supports can create that chronic stress, that feeling of being uncomfortable all the time. That can certainly elevate blood pressure and complicate treatment, because if social things change while someone may be stable a month ago on their blood pressure meds, but suddenly their life becomes very unstable, their blood pressure may also become unstable. So psychiatrists now tend to be more engaged in managing hypertension by integrating stress reducing strategies. And we mentioned cognitive behavioral therapy, we mentioned mindfulness, and integrating those techniques. Again, I think that this arbitrary distinction between mental health and physical health is really counterproductive. You sprain an ankle, the doctor may give you some anti-inflammatory medicine and have you follow up with physical therapy. On the psychiatry side, certainly some medicine for some mental health condition can be helpful sometimes, but therapy can also be a very important component of that treatment. So yes, a lot of different kinds of social determinants, other kinds of determinants, and then kind of a blanket recommendation for personalized integrated care that doesn't draw lines between mental health and physical health.
Well, thank you, Dr. Walsh. So we want to move on and talk a little bit about, again, some of the lifestyle changes that we want to talk about. And I know there's something called a way to do this with your diet. And there's something called the dietary approaches to stop hypertension, or DASH, and which is this diet is rich in fruits and vegetables. We've talked about this for years on Black Health Trust, a low-fat, low-dairy diet, along with reduction in sodium, and also regular exercise. We had one of our physicians tell us that we need to exercise 150 minutes per week, with about 30 minutes a day. Whether walking, resistance, or weights, or whatever you want to do with that. Also, we know about limiting alcohol, and also to avoid smoking, which happened without even thinking. But even with those, we still have people who require medication. And I want to go back to family practice. Dr. Hines, what do you do in this case? What do you do in primary care? How do you decide when to start medicine? And what do you start?
So often, as you were saying, right, as we talked about before, if we're talking about when you're in this category of like elevated or stage 1 hypertension, that's when we have the most kind of leeway and time to try to talk about some of these, therapeutic lifestyle changes, for example, how you eat. One of the things that I'm happy to see over my years in practice is that we've started to take a much more realistic and comprehensive approach to making these dietary recommendations. We used to just say, hey, here's the DASH diet. I'm going to show you a little diagram. I'll give you a sheet of paper that says, you can have a half a cup of this, or you can have, a hand, a palm size amount of this. And surprisingly, right, those things didn't work for people. And I think part of that is we weren't really giving enough weight to the challenges that are present when people are trying to change their diet, right? So it's not as simple as, just start eating healthy foods. Let's not take for granted that everybody understands what is considered a healthy food. For example, ramen might seem like a healthy food to somebody. It's not fried, there's no meat in it, right? But it is loaded in sodium. All you did was add water. It doesn't seem like it could be something that is inherently a problem. It's cheap. It's readily accessible. I can get it anywhere. And you could be shooting your blood pressure efforts in the foot because you decided to try to make some seemingly healthier food choices. Additionally, what we've come to understand now also is the impact of ultra processed foods. Ultra processed foods are essentially all the things that are coming in a package, right? Which all of us are eating. And they are intentionally designed to make us, to certainly be essentially more addictive, right? And make it more difficult for us to put the brakes on when we're eating them because they taste good, right? Like I like Doritos. I'm not supposed to eat them. If I have them in my house, I will eat them. So one of the first things I always would tell my patients is don't buy stuff that you're not trying to eat. If you're not trying to eat it, don't even bring it in your house. And lots of times it would be the rebuttal would be, oh, but my kids like it, or my spouse likes it, or whatever. There is no diet, I'm using diet loosely, that is recommended for control of your high blood pressure that is not going to be a win for your entire household, right? So you're doing everyone a favor, whether they like it or not. And for the other grown-ups, right, they have money, they have access, they can go get their own stuff. Especially for the kids, the problem will be we'll tell our kids to eat healthier, but we'll keep bringing in all the foods that they're not supposed to eat. And then say what? Don't eat it? That's neither realistic or fair. I think some of the other elements of eating that have kind of gotten by the wayside is the part where you actually pay attention to what you're eating. For example, when you're mindlessly eating, when you're eating, while watching TV, while driving, while whatever, you don't even realize what it is that you're consuming. Because sometimes you're making the right food choice, but you're eating too much of it, or you've prepared it in a way that is not, it was fast and it was convenient, but the health value has gone out the window, right? So also being able to identify your patterns and what you like. So some people might like Brussels sprouts. If you don't like Brussels sprouts, but you're trying to eat healthy, don't try to force yourself to fit into somebody else's model of what is considered a healthy diet, right? In addition to learning how to cook things, right? There was a time, I'll say Brussels sprouts again, there was a time when we used to boil the mess out of Brussels sprouts and then force people, right, to eat them. They didn't taste very good then. They were mushy and all kinds of things. Now, people are cooking Brussels sprouts in a different way, and they're all over the place in restaurant menus and things like that. Where in 1982, if you'd have said Brussels sprouts are on the menu, you'd have been like, what? So sometimes learning how to cook things in a different way can also be helpful. And lastly, I'll just speak to know what your values are, right? So Dr. Maxey mentioned several things that are part of a therapeutic lifestyle change. So quit smoking, stop alcohol, eat fruits and vegetables, go exercise. Like, here's the thing. Figure out the things that are important to you and that in that space, and then start with those. Start with doing those in a way that is meaningful to you and is aligned with your actual lifestyle. Again, if you don't have the space to go, biking, right? Then don't set biking as your goal, or you hate biking and it makes your butt hurt, right? Don't pick
Right.
that unless you can make the appropriate adjustments to make it a comfortable experience. A lot of us try to do what we see others doing instead of trying to find something that fits us, and then we wonder why we're not successful. And then also setting some reasonable goals. You're not going to overhaul your diet in a long-term way overnight. Those short-term fixes don't stay. No one's going to last just on baked chicken and green salad, right? And boiled eggs and avocado for 6 months, right? It's not going to stay. You're going to get bored. And then here's the other thing, recognize and prepare for the ways that people eat outside of just hunger, which is another big thing. We socialize around food. We celebrate around food. I mean, we mourn around food. Like, food has a lot of other meanings instead of just being fuel. And all of that plays a role when you're trying to change your diet for the better. And again, talking about those things with your provider can help you come up with some realistic goals so that then we can really do a real trial of those therapeutic lifestyle changes. And like I said, even if you get to your 3 to 6 month mark and your blood pressure hasn't changed, that doesn't mean stop them, right? You might have to get off medication in the meantime, right? Until you can find a pattern that works for you. Therapeutic lifestyle change never goes away. No matter, even if you're on medicine, therapeutic lifestyle change never goes away.
Thank you, Dr. Hines. I want to talk about a controversial area in medication for high blood pressure. And feel free to disagree with me if you want, but there are several main classes that we use. There are diuretics, which means they make you urinate or pee and get rid of excess water. And that can cause high blood pressure with excess water if the blood vessel walls get saturated with sodium and water. So that's why we want to get rid of water in some cases. There's another class of drugs called calcium channel blockers. Dr. Hines mentioned one before called Norvasc or amlodipine, and that tends to dilate blood vessels as well. And then there are two sets of drugs called, one is ACE inhibitors, which I don't recommend for African Americans or Spanish, but I usually recommend something like angiotensin 2 receptor blockers, or ARBs, angiotensin receptor blockers. And those are mild and they work fairly good. And then there's a drug which is direct vasodilator blood vessels called hydralazine, and we can give that in moderate doses. And there are studies from the past that show that if you use at least 2 and sometimes up to 4 drugs at a low dose, lower than their side effect profile, you can control blood pressure better over time. And that does work for some people. But I want to speak to some of these particular things. I had an incident where there was a 79-year-old man who was told to take a drug called losartan. He was also told to take amlodipine, and he was told to take Lasix, unbeknownst to anybody. And he had a habit of not drinking and not eating. And what happened with that combination of drugs? It happened that he ended up with a sinkhole episode, had to go to the emergency room, and probably he was dehydrated both because of not drinking water and also because of taking a diuretic, which nobody knew about, including his wife. And he was supposed to be taking a low dose of losartan. Losartan is one that we recommend many times for older people because it doesn't have very many side effects at all. And it's a good way to help preserve the kidney function by decreasing the pressure inside the kidney. So that's something we should know about. And I believe that many times in patients like that, you might want to start them with a low dose, single or two drugs, and then work up a number of drugs. But it takes anywhere from 2 to 4 different medications to adequately control blood pressure. And if you know, many times in a doctor's office, your blood pressure goes up, and home it seems to be lower. But the thing about that, I take blood pressure off to have a person run in place for 1 to 2 minutes. And that will tell me whether or not they're controlled. If that blood pressure goes up more than 15 millimeters of mercury, I know they're not controlled and I might need to increase that. But so that's a little bit on drugs. We can talk more about it if we have time later or another time. Dr. Stevens, what about drugs in kids? I know that's something that's sensitive. Do you use drugs in kids?
Uh, drugs in kids, most drugs have not been studied for use and or carry the recommendation below a certain age level. But those kids who have, and the first line approach for kids is still the recommended first line approach is lifestyle modification. But if you have a kid that has a significant hypertension, especially if they're in the category of high risk for other reasons, genetic or kidney disease, something like that, then the drugs are used with them. But children who don't have those special risk categories, they always start off with the lifestyle change approach.
All right, well, thank you. Dr. Walsh, and everything you say overwraps a lot that we're talking about, from medications to lifestyle change to everything. From your standpoint in mental health, how do we tie all of this together with even something called shared decision making that you make with the patient, individualizing patient goals? How would you look at some of this?
So Dr. Maxey, it really is, it really goes all the way back to our colleague, Dr. Jordan, who talked about always having a primary care provider, having someone who you could talk with, someone who you can trust to give you good advice. There is a need for us to monitor from the mental health side or the mental health focus what's going on with the general health of the individual. And for if you've got the family practice doc or the pediatrician or the internist working with someone who also has a psychiatrist working with them and folks are prescribing, it's important to look at not only how the medications may interact, but also how some of the hypertensive drugs that, like we talked about earlier, can impact mood. That monitoring is especially important because you'll find that as you prescribe some psychiatric medications, they may improve mood, but they may not improve mood initially. Initially, there may be some side effects, maybe some folks don't feel the same as they would in the head. Sometimes folks may feel upset stomach and irritable and not eat normally. There are a lot of different kinds of things that may go on with medications. So from that psychiatric standpoint, you want to look at how the drugs that you're prescribing are going to impact mood, how some of the antihypertensive drugs may impact mood. And so monitoring that, and again, keeping an open line so that folks know you want to hear from them if they don't feel like themselves, or they feel like instead of their blood pressure just getting better, their mood is getting worse. So sometimes one of the medications that you would ask I would ask a patient to ask their doc about is their primary care doc considering the fact that their antihypertensive medication may be impacting their mood? For example, there is evidence that calcium channel blockers for high blood pressure may be preferred because they may have fewer mental health side effects. But again, when we talk about shared decision making, this is this particular individual and this individual practitioner. And so it's not, it's sort of like deciding that because the person is driving a Chevrolet, you automatically know that it's a transmission problem, or if they're driving a Ford, you automatically know that it's a radiator problem. It doesn't work that way. Our bodies don't allow you to just predict based on male, female, young, old. We really do need to have that interface and that shared decision making.
Before we close, I want to hear Dr. Neighbor Stevens talk about how do you handle shared decision making with children and their families? How do you handle that?
Well, I would argue that's the fundamental bedrock in pediatric practice. You are always dealing with a family unit. Now, in the older child, the adolescent, there may be some subjects where you need to have a private conversation with the adolescent, but earlier than that, generally speaking, it's going to be a family affair. And whether or not the child agrees to something isn't one would hope, but isn't rate limiting, because in most instances, whatever it is you're talking about, whether we're talking about high blood pressure, obesity, or asthma management, doesn't matter. There's going to be someone involved in the supervision and I won't say enforcement, but making sure that what has been recommended is followed. But in order to have that happen, you need to always make sure that the adults in the room, so to speak, are one, understand what it is you're talking about and what the goals of therapy are, and whether or not they are in agreement. And then again, besides just agreement, you want to make sure that whether the family has other members that have high blood pressure, or if the whole family is obese, which frequently is the case, or several family members have asthma, you want to make sure that the family understands what is going on and how they can improve the ultimate outcome.
Hey, given your answer, I want to ask one more question that I'd like all four of us to comment on. I was involved in a discussion a week or so ago, and the question became, at what age does a young person have the right to make their own decisions or to not have their medical information shared with their parents? And just from Dr. Hines and Dr. Neighbor and Dr. Walker, just comment on that a bit. How do we handle that situation? Don't tell my mama I'm pregnant. Don't tell my daddy I have a STD. What's our obligation as physicians to deal with that?
Well, first of all, that varies to some extent from state to state. So a practitioner needs to be aware of what the legal guidelines are in the place where they are practicing. But if whatever the guideline is, whatever the age is, in some places as young as 14, in some places as older, 16. But whatever the age range is, I was trained that you try to facilitate communication between the child and the parent. So whatever the condition is that needs to be communicated, you try to get the young person to understand why they need to involve their parents. And sometimes it's very difficult. A lot of times it may be difficult, but that's part of your role as the pediatrician to help the family communicate.
Dr. Walsh, Dr. Hines, any thoughts?
I'd agree with Dr. Neighbor Stevens. I've been in that situation with young adolescents on many occasions, and part of it is understanding why don't you want to tell your parents, right? Because sometimes there are legitimate reasons why they may not want to share, but overall, recognizing that our role in that, doctors, is also a bit of a counselor, right? Like, and to kind of walk you through the significances of not telling anyone, well, how are you going to manage that, right? How's that supposed to go? And sometimes you can help them see where they're going to need a trusted adult, even if not their parent, to help them through certain types of situations. Um, and then there are also times, where, to your point, where, there are just certain instances where I'm not allowed to tell. So I have to, based on what the laws in the state are. So
I want to
Thank-
make one additional comment. I don't believe there is any state that does not have laws in place where if you have reason to suspect child abuse, that you do not have to have anybody's consent. You are obligated by law to make that report.
Good point. Dr. Walks?
Yeah, I'm glad that Dr. Neighbor Stevens went back to that, because sometimes the reason that someone doesn't want to tell parents about being pregnant is because one of the parents is the person that precipitated that. And so it does fall into that category of child abuse. I think also the point that Dr. Hines made is very important. Giving someone, when I was a kid, a good reason for everything was because I said so. When my parents would just say, why? Because I said so. Nowadays, I think it's not only important, but it's useful to help somebody understand, as Dr. Hines was saying, about the need for resources. Well, let's talk about how you would manage this if you didn't tell your parents. Or is there a trusted auntie or a trusted uncle or someone who is going to help you with this? So, yes, that counselor role can be more clearly expected in the mental health space, but I think it's anytime someone is coming to you as a trusted provider, you really should try to see yourself in that facilitator role, because if there's a young person with a problem and the family can't come together around that, it really indicates that there may be some additional referrals for family counseling or some kind of a way to kind of bridge that gap. It's without getting overly dramatic and preachy, it's a tough world out there by yourself. And if you're 14 or 16 years old and you think that you and your 14 or 16-year-old friends can manage the world in a way that's going to, in the long term, be helpful or positive for you, I don't know. That ain't ordinary. And so I think being able to allow people to understand in a way that they can then implement that, reaching out, risking, letting folks know that there's something going on with you that maybe they can help you with, is again part of our role. How do we facilitate counsel? And even though if somebody comes to see you in your office, it's not quite the same thing, but think about it like a discharge plan. If you're leaving the hospital, they usually give you a discharge plan. This is what you're supposed to follow up with. This is what you're supposed to do. This is how you know that your post-operative wound or thing is healing well and all that. And so helping folks understand that once they leave the practitioner's office, these are ways of knowing that things are going okay. You are walking through the neighborhood 30 minutes at a time. You are eating something that's healthy. You are. So that kind of a discharge plan, not only on the mental health side, but on the taking your medication side, set an alarm on your phone so you can take it twice a day. Oh, by the way, no one takes medicine 4 times a day. Hey, don't do it. They don't do it unless you're in the hospital and somebody is giving it to you.
Thank you,
People
Dr.
don't do that. But
Thank you.
being able to have folks agree that whatever the discharge plan is, whatever the after you leave the office plan is one that is doable and people commit to doing, I think is important.
Well, thank you so much. Are there any questions in the chat? Anybody want to make any comments or suggestions from the audience? Is there anything in the chat, Dr. Neighbor?
No, you don't have any comments.
All right, well, I hope everybody enjoyed our discussion. I appreciate the participants. I appreciate Dr. Neighbor Stevens, Dr. Walsh, and Dr. Hines. And care for some last words, starting with Dr. Hines?
I would just say the crux of our discussion has largely included a good bit about shared decision making, the days of paternalistic medicine where the doctor told me to do it, so then I would just do it. Like those days are over. Shared decision making leads to better long-term adherence, and it's empowering for your patients, and it's empowering for you as an individual to understand why you're doing or not doing a
Say,
certain.
can I raise an issue with you, Dr. Hines? Why did you say paternalistic as opposed to paternalistic? Go ahead, Dr. Walsh. Go ahead, Dr. Walsh.
I would say something that I say to my patients is I don't believe in doctor's orders. I believe in doctor's agreements. And I say that because I think it empowers the patient to let me know what their opinion is and let me know if they have a different opinion about whatever it is that I may think. So as Dr. Hines said, doctor's orders were really, really good 50 years ago, but doctor's agreements mean that you may actually be able to help the person you're working with.
And I would say to you, Dr. Walsh, I can't imagine a young South American lady would say to her kid, because I said so. Dr. Barbara Neighbor Stevens.
I want to kind of take what my colleagues have said to the next level, which is what we have always tried to do at Black Health Trust is to give you the information that you need to be able to advocate for yourselves. And I'm not pointing fingers at any particular person, but I'm going to say to you that not all practitioners are as up to date and knowledgeable as they need to be. So now that you have heard some of the information that we have given you today, the changes that have occurred in the approach to the management. Today it was high blood pressure. Other days there have been other conditions that we talked about. Now that you have this information, you can go in to your provider and have some level of expectation in terms of their performance and hold on to it.
Well, thank you so much. My last word will be on 2 points. One, when you have high blood pressure, you should make sure that you have a good physical exam from your provider. They should also draw certain laboratory, including your blood glucose, your creatinine, your BM, what we call a chem panel, a full chem panel. They should also look at your urine, look at your protein in your urine, and make sure that you get those results back. They should also take an EKG. They should listen to your heart. They should make sure that you have a chest x-ray because there's certain things that you'll find there. And make sure you get a complete exam and they explain what the results are. The last thing I want to say is increasingly important. Make sure that you cast your vote in the next few weeks for those people who will support your community. That's very important. People who decide that you are important, your life is important, and your community is important. I thank everybody very much for their Sunday afternoon. Thank you, Simon. Have a great day.
Bye.
Good day, everyone.